Hello everybody in Brazil. My name is Lars Timmermann. I'm from Germany, which is the country with the probably highly successful soccer team at the upcoming World Championships. However, I'm sad to say that probably they will be defeated by your team. However, today here we spoke about Parkinson's disease, and I think there are a number of very good options in advanced Parkinson's disease. They should be considered in our everyday clinical life. One of the things is certainly that we have now an armamentarium of different potential medications that might lead to an improvement of either wearing off but also dyskinesias, which is MAO-B inhibitors. There are also COMT inhibitors. There's the potential of prolongation of drugs and of a frequent delivery. However, in some of the patients we're not successful in that. And in these patients we have currently with apomorphine, with duodopa, the L-dopa intestinal gel, as well as with deep brain stimulation, very good options. Essentially what we see and what we've discussed here is that the evidence for levodopa-carbidopa is now very good. After a randomized double-blind, double-dummy trial has been published in the Lancet Neurology by Olanoff et al. What they found essentially was that there are a number of patients with problems with the tube, but taken together, compared to immediate release oral levodopa, we are getting very nice and sustainable effects, not only on the everyday diary with a much better on time and much less off time, but also a number of other very positive effects. In apomorphine, there's also very recent data showing that despite the problem of nodules and also potentially hallucinations and other psychiatric problems, we're getting with apomorphine a very nice and smooth daily profile. So far there has been no class 1 evidence trial. However, apomorphine is efficient in younger patients with a good dopa response to make a sustainable improvement in their everyday diary with more on time, much less off time, and with totally less dyskinesias, which might be a proof that the concept of dyskinesias induced is rather true. And last but not least, deep brain stimulation. There's considerably very good evidence that we not only can improve motor function, but really quality of life in patients with deep brain stimulation. And this holds true not only for the classical motor symptoms, but also for the non-motor symptoms. And this is also true. We're very happy to see that new developments come up with deep brain stimulation. Systems that allow interleaving stimulation, but also systems that allow multiple source current stimulation, allow that we really get a profound and much better benefit. In our European trial, we had more than 40 patients with an improvement in the UPDRS, the basic motor score, of more than 60%. However, we have to take care that we do not operate patients with axial symptoms, and that we take care whether they develop some sort of problems in the psychiatric domain, that they get some behavioral differences, or maybe also that their expectations are not met. Taken together, adjustment of medication, a good candidate profile for apomorphine with the younger patients, and also the options of levodopa are in the conservative part, rather very good options, and deep brain stimulation is going to be a very good option, especially in younger patients who will receive a sustainable benefit. Thank you, and my best greetings to Brazil.